So we'll get started. So, I know that the return of our lunch is very exciting for everybody, and I'm very glad that we are able to resume our lunch for our grand rounds. And today, actually, it was supposed to be a combined grand round with neurology, but our endowed lecturer who was supposed to give a talk on functional neurological disorder couldn't make it. So we suddenly had this blank spot, and I'm still regretting, but I volunteered to pick up that spot because every year I give this annual update about the department, but I don't get to talk to you as a fellow, I guess, researcher in this time. And I thought maybe it's a good time for me to at least talk to you about some of the research that I've been doing and I've been finishing, actually. That's also another thing. Because I know that quite often I relate to you as a clinical leader. And I also relate to you time to time as a education leader. But I haven't talked to you about research side of it. My research portfolio has gotten smaller and smaller. So I don't really have that much, but I do my best. And I don't know if any of you actually remember this slide, something titled A Psychiatrist Among Surgeons. And this was when I was actually still at Yale. I came here around November of 2016. And I remember that day particularly because it was the election day for the president, actually. And this was actually my job talk, the psychiatrist among surgeons. And I was talking about how I was utilizing surgery as a research paradigm to study neuropsychiatric syndrome. And part of that talk was about this NIH R01 study that I was working on and about to complete, a NOAA study. And now, why am I bringing this up and talking to you now? Well, as I talked about it, there are things that change and there are things that stay about the same. Now, 2016, I had a hard time finding that picture of my two kids. They were still in high school and middle school. And Donald Trump was elected just as a president, and now that almost a decade later, there are things that have changed, but there are things that have not changed, and then he is, to my disbelief, still the president, and our department obviously has gotten a lot larger. And we serve more people than ever. In fact, I'm not sure how many of you even remember when I arrived. And my kids obviously have grown a lot. I'm an empty nester. The kids who was in middle school is now in college, and another is now in medical school. And recently also, Mark Oldham, my collaborator, who's also faculty in our department, published probably the last paper from that particular study that I spoke about when I first arrived here in 2016 called the Neuropsychiatric Outcomes After Heart Surgery Study. And that's basically what I wanted to talk about. Now, before I do that, it contains the word neuropsychiatry. So I'll talk about what neuropsychiatry is about because I've had some thoughts about that. And I'll talk about the vascular depression hypothesis, the late life depression that at least like many geriatric psychiatrists are familiar with, and the development and findings from the neuropsychiatric outcomes after heart surgery study over the past almost a decade. And the lessons learned and the future directions and is another thing that I'll talk about. So why am I repeating this talk? Well, part of it is motivated by that. Recently, I was asked to give a talk for American Neuropsychiatric Association, and Academy of Consultation Liaison Psychiatry. It was a sort of collaborative grand round they are holding, and I was asked to give a talk. And I was thinking, oh, what do I talk about? And why was I asked was another thing that I was kind of thinking about. I guess, I mean, there was a reason as to why the American Neuropsychiatric Association asked me to give a talk, because in reality, I'm actually a neuropsychiatrist. Now, many people don't know this, but at least a lot of you actually do know that I'm a dementia specialist. I have a regular memory care clinic, dementia clinic that I attend, and even now. And EJ Santos is my boss, actually. And now, in order to prepare for that work, I did a neuropsychiatry fellowship at Johns Hopkins between 2001 and 2003. And you are looking at a picture of Vani Rao. She's a TBI expert. And at that time, the Division of Neuropsychiatry at Johns Hopkins, Kostas Liketsos, who became my mentor, was the division chief at that time. And now this was before behavioral neurology and neuropsychiatry fellowship became officially a UCNS approved fellowship. So I don't have the actual certificate as a BNNP fellow because it happened right before. Instead, why am I nowadays working a lot in the consultation liaison psychiatry world was that, I was the youngest faculty in the department. And apparently the Department of Psychiatry at Hopkins needed 2 CL psychiatrists who has a specialty board to establish a fellowship. So I was drafted to take the board. So I had to take Johns Hopkins Hospital is a bit strange in that sense that there was this tradition that nobody took ABPN board for psychiatry at that time. So I had to take the general board first, and then psychosomatic medicine board, which later changed the name to consultation liaison psychiatry. And that's how I became consultation liaison psychiatrist rather than a neuropsychiatrist. So, and then later I became the chief editor for the Journal of Academic Consultation Liaison Psychiatry. And I established the neuropsychiatry section because that's a subject that I really like. And I also founded the neuropsychiatry special interest group. And out of that relationship, when there was this joint conference, joint grand round, I was asked to give a talk. So what is neuropsychiatry? Well, it's a specialty medicine that essentially what it does is it integrates the fields of neurology and psychiatry. It focuses on the boundary between these two fields, and it focuses on the diagnosis, treatment, and management of a condition that relates to neurological and psychiatric symptoms. And the scope of the field includes any brain disorders that affect behavior, cognition, such as like dementia, stroke, epilepsy, TBI, and sometimes includes sleep disorders, and broader definition sometimes even includes IDD population related to intellectual developmental disorders and autism spectrum disorder, and etc. So neuropsychiatry can be really broad sometimes. Now, this is probably a good illustration of where it lies. It really lies between psychiatry in which that we focus on the mood, affect, thoughts, and behavior, versus neurology that traditionally focus on motor symptoms and sensory and symptoms as well. But somewhere between is attention, alertness, perception, memory, language, cognition, motivations, and etc. that neuropsychiatry focuses. And it's a very multidisciplinary field because there are psychiatrists like neuropsychiatrists. There are also behavioral neurologists. There are also neuropsychologists that we also have a couple of them in our department. There are more in neurology department. And we tend to work together and tend to refer patients back and forth. And sometimes there are some tensions related to, who owns what. But overall, it's a field that overlaps a lot. And behavioral neurology, in fact, is what our neurologist colleagues call that field. And the neuropsychiatry, they sort of developed separately historically. In fact, American Neuropsychiatric Association is primarily for the neuropsychiatrists, those who have background in psychiatry, versus Society for Behavioral and Cognitive Neurology is primarily for the neurologists. But there's some overlap in terms of membership as well between neurologists and psychiatrists. And eventually, in 2003, they decide to apply for the joint subspecialty. They decide to combine the forces together, and then subspecialty called behavioral neurology and neuropsychiatry. They defined it as a medical specialty community to better understand links between neuroscience and behavior and to the care of individuals with neurologically based behavioral disturbances. And the UCNS, the United Council of Neurology subspecialty, approved it in 2004. And there are 47 behavioral neurology and neuropsychiatry fellowship programs around the United States and Canada as well. We have one that was just approved last year, and David Gill in neurology department is the director, and our own Emily Clark is the associate director. And I wonder, I hope that some of our trainees take interest in this, and because we do have slots available. And our department, from the get-go, when I first arrived here, one of the things that really attracted me is that there's a lot of neuropsychiatry in our department. In fact, if you just kind of forget about neuropsychiatry separate area and just count what can be considered part of neuropsychiatry, we might be one of the top 10 largest program in the country easily. Because very few program has, very few psychiatry department program has as much dementia-focused program as we do. So we have a lot of dementia-related programs through the memory care program and AD care program led by Anton Thorstensen and Finger Lake Center of Excellence for Alzheimer's disease. We take care of 60 nursing homes around New York State through work of EJ and others through the geriatric telepsychiatry program. And the GUIDE program just started, value-based program to take care of dementia patients and their caregivers, a lot of programs. And on top of that, we also have embedded pretty large psychiatric services, Article 31, Article 28 program in the neurology clinic in Clinton Crossing with 3 therapists, one full-time a psychologist as well as a half-time psychiatrist as well. And also William Watson is also embedded in the epilepsy program as an expert who does the pseudo-epilepsy related area. So, if we want to, we can just group them into neuropsychiatry, and we probably have a program already. But as it is right now, it's distributed between CCW division and a geriatric psychiatry division. Now, just moving from that to my focus on my talk is my venture into neuropsychiatry research. So when I was a neuropsychiatry fellow, remember, I was interested in dementia, and I was very interested in dementia prevention, particularly from the angle of this diathesis stress sort of model in that sense. One of the things that I always was wondering about when I was a trainee, as a resident fellow, even now, is that why does some people develop depression after, let's say, some sort of a incident, and that incident is perceived as a trauma, while another person perceived it as not trauma and be able to go on. And that idea of what makes one person different from another is something that I always was wondering. And that also related to the thought about why do some people develop dementia and why some people don't develop dementia. Now, there are lots of different factors, like genetic factors and environmental factors or whatever it is. But why is someone more resilient than another? And that's something that I always was wondering. And as someone who was interested in dementia, I was very interested in this idea. Maybe depression is the stress that relates to overall development of cognitive decline in later life. And that was my what's called K23 grand topic. Now, you know, it's been really long time since I even looked at the title of it. It's because it's like 2004, that's more than 20 years ago, and when I was a neuropsychiatry fellow. And the idea was even though I think it was a pretty good idea in that sense, I was really taking advantage of this really pretty well-known, I don't know if anybody's famous of heard of this study called the ECA study. ECA study is something that our NIH sponsored 5 sites around the country during the 1980s to kind of quantify what is the burden of mental disorders around the country. It awarded that project to Hopkins, Yale, UCLA, I think one in Midwest, 5 sites. And all the estimates that we have about, 5% depression prevalence and anxiety prevalence and et cetera, it's all from that particular study. But Johns Hopkins was unique in the sense that it was the only site that decided to follow over the next 2 decades. And using that particular cohort, I decided to study, does exposure to depression during midlife leads to increased risk of developing cognitive decline and dementia in later life? And I'm probably speaking way too much because the study itself really bombed. Research is really hard, actually. Now, why this is hard? Sometimes after you get funded, let's say for 5 years, sometimes within 6 months, you're in trouble. And this was the distinct feeling that I had, because what I did not appreciate at that time was the issue related to attrition of the cohort that was really affecting, because it started with about 3,500 people. Over the time, as it went through first wave, second wave, and third wave, by the time it went down to about 1,071. And then out of that, I'm trying to do one more cohort, and it was really hard. It was really hard also because it involved a lot of measurement. It also involved home visits. Now, some of you have spent time in ACT study, right? ACT team, and you've seen how we do home visits. Now, think about that versus me and my research assistant doing a home visit in Baltimore poorest neighborhood. It's quite a sight. Having said that, there are also enjoyable moments, and there are a lot of things that I learned as well. And I look back actually with a lot of fond memories as well with my research assistant, but it was really hard. And I knew that this was already in trouble. And then I was also already thinking, wow, this is getting really difficult, because thinking about how I quantify these stressful events prospectively as well as retrospectively based on this cohort was really, really difficult. And the other reason as to why this kind of study is really hard, an epidemiological study, is that incidence is just too small. Eventually, what I realized is that cognitive decline number is too small and my sample is dwindling so fast. So I decided to switch over quickly within 2 years. And what did I decide to switch over? Well, I decided community cohort is way too difficult to do. And also it takes too long to keep following these patients. So I wanted to work with something that's more accessible to me around me at that time. I was in a hospital and I thought, well, surgery is very accessible. How accessible? 331 million major surgeries around the country per year. And there are lots of surgery whenever you go to hospital. Okay. So I'm thinking, oh, maybe this is a better clinical research paradigm I can utilize and be able to work with it. Because it's scheduled quite a lot of things, especially if it's done and they come to you. And then there is this single stress of surgery. So in other words, that you can measure the diathesis of a person as they are as a patient, and then there is surgery as a stress, and then you can kind of see who develops depression, delirium, or cognitive decline. And in some surgeries, this is very reliable in terms of what is the number of these incidents of delirium, depression, and cognitive decline within relatively short duration of the follow-up. So I thought this might be it. And the one that I really focused on is a coronary artery bypass graft surgery, so-called CABG surgery that happens about 300 to 400,000 cases per year. Used to be higher before people developed, lots of technological advance in percutaneous coronary intervention, angioplasty, and etc. And that's what I was thinking. So this is really common, and maybe this is something that I can work as a diathesis stress model in relation to really thinking about it, especially because some of these neuropsychiatric syndrome was very reliable after coronary artery bypass graft surgery. Particularly depression at that time was gaining a lot of attention because about 20 to 30% of the patients after the surgery within a year tends to get depressed. And subthreshold depression seems to be even more common. And with that, not only that, it seems to be associated with unexplainable morbidity and mortality. Some studies has odds ratio of 3.5 and four times higher likelihood of death after developing post-CABG depression. And it's been repeated, and there are many meta-analyses related to that. Actual cause of it, people still don't know. But I'm an epidemiologist. I'm not particularly interested in the mechanical aspect of it. I'm simply interested in identifying reducible risk factor of perhaps if there's a way to reduce post-CABG depression by studying the diathesis and variety of factors, maybe I can reduce post-CABG depression and subsequently post-CABG morbidity and mortality, was kind of prolong the kind of logic that I was developing. Okay. Another reason as to why I was really curious, because I was one of the authors who wrote this paper about when do people get depressed. There is a subgroup, if you look at this overall, this is an incidence curve. So a lot of people get depressed starting around age number 30 to 40s, particularly peaks, and then gradually goes down during the 60s. But there is this little bump there between the age of 50 to 60. For the female, there's a later bump that happens. What is that late onset depression? Now, for the geriatric psychiatrist, this is an area of interest, thinking that this might be a different type of depression altogether than the early onset depression. And one of the theory is called vascular depression hypothesis. Hypothesis is relatively straightforward. The cerebrovascular lesions predispose, precipitate, or perpetuate depression in late life. And it should have evidence of vascular disease or risk factors, particularly through neuroimaging. Generally, it is thought to happen late onset. Like every investigator seems to define it a bit different, but age of 65 is as late as some people define it. And generally, there are secondary features, particularly related to the cognitive impairment in the executive function area. And because it's more of a vascularly mediated, there should be less family history, less, and also anhedonia related to some of the circuitry-related issues, and psychomotor retardation. And though that's what generally is what is said. So essentially, the idea is that is there some kind of diathesis? And this is an extreme form of somebody who has lots of white matter hyperintensity in the brain. Is there a diathesis for that particular group of people that develops depression in late life, that little bump there? And that's what I got very interested in relation to this. Because, well, there's also, like as a neuropsychiatrist, I was also very interested in post-stroke depression as well. The idea that left hemisphere stroke causes depression. Bob Robinson, who is a hero to many neuropsychiatrists. And here's a vascular depression that seems to be like a cousin to it. And essentially, there have been lots of neuroimaging studies that have shown that compared to the people who are without depression, that to the left of these pictures, I don't know if I can, right there. And people with depression has these white matter hyperintensity around the preventricular area. And that is the basic driver of this, of many repeated findings that people have developed. The reason that I was struck with this idea was that, well, the post-Cabbage depression, there's a lot of epidemiological similarity. One is age of onset. Well, in vascular depression, it's late onset, obviously, but in post-Cabbage depression, because generally elderly people have these surgery, it's also age of onset tends to be, if they develop it for the first time, tends to be also new as well. And presence of vascular risk factor is very important in vascular depression. And of course, people who are getting Cabbage surgery is full of vascular risk factors. Cognitive impairment, I talked about executive dysfunction, very common in also vascular post-Cabbage depression as well. And they tend to do a bit worse than the idiopathic major depression for both, poor response to the treatment, and sometimes it's associated with mortality, higher mortality as well. So there are these interesting similarities that I was thinking that the question then becomes, is post-Cabbage depression a vascular depression? The other reason that this is also, to me, is interesting is that despite all that evidence, prospective direct testing of the vascular depression hypothesis hasn't quite happened by then. What I mean by that is that most of the data that has supported vascular depression hypothesis has been either retrospective or cross-sectional. So in order to truly prove that this entity exists, then we should have some kind of prospective testing, people with all these brain lesions versus without. And if you have this stress to these people who have different diets, if you have this stress, then one group should develop more than the other, right? I mean, that's the basic idea behind it. But there are a lot of criticism at that time as well. The lack of definition was one of them because people couldn't quite agree what should be the, I mean, there are some proposed criteria that was floating around, but many studies were using different criteria. And the causal direction is also confusing because depression is already a known factor for cerebrovascular lesions, and cerebrovascular depression is also a known risk factor for heart attacks. So what comes first, depression first or the heart disease first or cerebral vascular disease first? So the direction seems to be bidirectional. So there has been a lot of questions related to it. To this day, there's still a lot of questions. So I decided to do this study. Okay. Why did I name it NOAA study? Don't laugh, Kim. This is the neuropsychiatric outcomes surgery. That was my son. And I'm spending way too much time in the lab. And so I decided, and that's him holding this stethoscope that I still have. And so I got funded, which is good. Okay. And then the idea was, again, now I couldn't do MRI because it was going really fast. Those people who wants to have a coronary artery bypass graft surgery, they don't like to have a lot of procedure before the surgery, at least at that time. It was also expensive at the time. So I decided I use something called transcranial Doppler to measure intracranial stenosis as a way of sort of proxy measure of the white matter hyperintensity in MRI, ischemic changes, and etc. And then, the idea is that if you have a lot of these intracranial stenosis measured by transcranial Doppler, you will go on to develop major or minor depression after CABG surgery, stress and diathesis. And then look at the longitudinal course and symptomatology of post-CABG depression as a way of kind of looking to see, does it match the vascular depression hypothesis in relation to cognitive impairment, lack of family history, anhedonia, all these things, features and longitudinal course, somewhere along the line was what I was thinking. All right, transcranial Doppler was basically the tool that I was utilizing. It's a non-invasive and pretty reliable technology. If you have a licensed technician, it measures local blood flow velocity and directions as well. And it essentially measures the severity of intracranial atherosclerosis. Generally goes up as it becomes increasingly more atherosclerotic. And it's bedside, and it's also less expensive than angiography and MRI at the time by wide margin. Right now, I don't know actually, because MRI has gotten so inexpensive. But something, this is interesting. Nowadays, I don't know if you know, every medical student first year at University of Rochester is carrying ultrasound machine on their hands. And that's what I was imagining at that time. You could have a ultrasound machine in your hand that could make these the detections of variety of atherosclerosis on your body that can, and this idea was that maybe that will guide us. But right now, every medical student at the University of Rochester has this particular, they have a much more sophisticated one that they're carrying around. So here is a hypothetical model that I was pushing at the time, that we will look at this this intracranial atherosclerosis main diathesis with this surgery as the stress, and then depending on the status, people will divide into depression or into depression, and then we'll be able to measure that. Okay, and lots of work related to assessing them at the cardiac cath level, and then surgery 1 month assessment with a cognitive follow-up, as well as monthly telephone monitoring, and then 12 months assessment. And then visit schedule, I don't need to go through. All right, so study has been now completed. One of the first things that I did when the study completed, not the first thing, but later thing that I did is that there have been also suggestion, it's not actually the post-CABG depression that's really important, but it could be that pre-CABG depression is just as important. And I was just curious, and because the data has been unblinded already, why not just look at the baseline data, look to see if pre-CABG depression is actually a vascular depression hypothesis. And this is a paper that Joy Choi in our department wrote a couple of years ago. And there's this tantalizing finding that didn't reach a statistical significance because probably the power issue. because only 11 people had a baseline depression. And their MCA intracranial stenosis was detected, but it wasn't quite reaching the statistical significance level, somewhere around 0.062. So it wasn't that. And then, but what she did find is that there are some interesting findings related to functional impairment and cognitive impairment at baseline for these patients with pre-CABS depression. And based on that, she did a very nice job of listing this idea of looking at the vascular depression criteria as a way of sort of matching to see, does it fit? Well, probably the most important criteria, it didn't fit. Obviously, it didn't quite have the intracranial stenosis, but it has a really interesting neuropsychological findings, as well as lack of family histories, what I highlighted in the graph below right here. And there's no lack of past history. So this is a new onset depression. What I mean by that is that there is they have a history of depression. They also have a family history of depression. What I mean by that is that this pre-CABS depression seems to be actually a idiopathic recurrent depression, not a new onset depression. So in other words, that there are some features that matches vascular depression hypothesis, but by and large, it doesn't quite resemble vascular depression hypothesis. So pre-CABS depression, well, it doesn't look like, not quite vascular depression. Okay, I'm gonna just quickly accelerate into the overall finding of the study, okay? And this is the last paper that we wrote, okay? And Mark Oldham wrote this paper just now, just got released, and essentially, it's a completely negative paper. In other words, that after doing this follow-up for about a year, there's no association whatsoever in relation to MCA stenosis measured by transcranial Doppler. But what he instead found a strong predictor was actually a perceived social support. There are other things that he kind of found, but like having some cognitive impairment at baseline, also prior depression, as you would predict, would also predict post-CABS depression. But overall, there is no finding whatsoever. So having spent almost a decade in this particular study, I have very little to say about this study. No association, okay? And the only thing that was sticking out was this perceived social worker, perceived social support. And so, I mean, essentially, that's just saying that we did not find any association after all that. And, but it's sort of beginning to kind of wonder that maybe that's post-CABS depression then is very much like any depression in the community. So we decided to pursue a little bit more. How about then the personality vulnerability? And we actually did that analysis just this summer. And it does look like neuroticism, the usual personality vulnerability, very strongly associated with this depression. The post-CABS depression within our sample, it's more like people going through really hard stress and they have a personality vulnerability along with the social stressors of not having somebody to support you, as well as having difficult time in terms of coping with it, is basically what we are sort of evolving at this point. So is that all I found? Is that all I did? Well, that's it after spending a decade of this. But we did actually achieve a few other things as well. But actually, more precise way of saying is that Mark Oldham did a lot of work related to other aspects of it. Because in reality, NOAA study was about not just about depression, but we are also curious about other aspects of surgery as well. So we put a lot of measures in related to delirium. we assessed every patient after surgery from day 2 to time of discharge with clinicians, and we also did a very careful cognitive assessment, clinical dementia rating, as well as detailed neuropsychological testing, because not only depression common, but also the delirium was also common and is associated with poor recovery, morbidity, and mortality, as well as the post-CABG cognitive decline is also very well-known phenomenon. You know, after usually the open heart surgery, about 20% to 50% of people complain about cognitive change, so-called the pump-head phenomenon. But nowadays, like I think people do off-pump surgery as well, but it still seems to be associated with cognitive decline. And usually what happens, this is a meta-analysis that we wrote a while ago, is that about at 1 month, there is this substantial decline, and then there is a recovery period, but not quite at all the way to the normal. And then you know, at around that time, this was, I think, actually time when Mark Oldham and I were actually still at Yale. He was developing this really interesting ideas about delirium. And he published this based on this NOAA study, how the mild cognitive impairment at baseline predicts the post-operative delirium after the coronary artery bypass graft surgery. And at that time, the dementia as the risk factor for the post-operative, post-surgical delirium was very much established. But I think this is the first time, unless I'm mistaken, that actually established almost any cognitive impairment is a risk factor at baseline if you are going through surgery. And you know, it's also interesting. It was not the neuropsychological testing-based mild cognitive impairment, but a functional assessment. The clinical dementia rating was the high risk factor for 7.5 times more likely, by the way. I mean, it has wide interval rate, but that was another thing that was kind of striking. He also goes on to report another very interesting finding related to, remember I was talking about pre-CABG depression as a way of kind of thinking that maybe that's what's important. But he actually finds that it's actually the depression at baseline that predicts a cognitive and functional decline 1 month after coronary artery bypass graft surgery. And we couldn't do 6 months or 1 year because the attrition rate in our cohort was also pretty bad at that time. And that's the story of my life in relation to trying to hold on to these cohorts. And there is a substantial risk factor related to pre-CABG depression, and also some of the, again, confirming some of the more neurocognitive executive function as the predictor of cognitive decline is also another thing that he found as well. And later he, again, that this pre-CABG baseline depression appears to predict, even if you account for other factors, that it predicts the postoperative delirium as well. And there is also sort of this finding that we don't know what to make out of it because our sample was too small, that right MCA stenosis appears to predict the severity of delirium, and not the left side. And that's also another finding that we are intrigued and we always wonder about. Remember, like at the pre-CABG side, there was also this sort of subtle signal at 0.063 that that did not reach significance. So there is something about this pre-CABG depression and intracranial stenosis that we are not quite getting at, which relates to some of my regrets as well. There was also this sort of a little bit more detailed analysis related to how gender mediates depression, and also as the risk factor, that is MCA stenosis was only predictive in women, and mild cognitive impairment is only predictive in men. So there is some kind of gender difference as well. So just to give you overall summary, outside of those negative findings, there is some ideas about mild cognitive impairment diagnosis and CDI seems to predict post-CABS delirium, and pre-CABS depression seems to be predictive of both post-CABS delirium and cognitive decline as well. And there's some kind of role related to gender that we are not exactly sure what to make out of because there is about gender issue. So it goes back now, which I haven't really delved into it. What is the nature of pre-CABS depression that predicts post-CABS neuropsychiatric symptoms? Maybe I had it all wrong. Maybe I should have pursued post-CABS, pre-CABS depression rather than pre-CABS depression, and that's something that I'm right now homing over. So, with that, before I run out of it, I wanted to talk about some of the lessons that I learned. One is that research is a craftsmanship. It's a craft. It takes years of practice and specific skills and crafting right question, analyzing it. It really takes dedication and skills and to produce high quality, impactful results. And I still kick myself for sort of thinking maybe, I just was not a good enough researcher. And I have a lot of respect for people who are now, fully making their career on research because they really are dedicated in quality and making sure that it runs well on the protocol. I think I was already distracted. I was running a division, and in the middle of the analysis and finishing up, I was obviously recruited here, so I had to wrap up really quickly some things. And I have my regrets. This attrition rate is something that I really regret. 161 to 89, that really reduced the power. And the other thing that I keep thinking about is that I had an opportunity too, because I had funds as well, to do a case control study too. Rather than relying on transcranial Doppler, I could have done case control study, people who develop post-CABS depression versus people who didn't, and really compared to MRI. And that would have been really nail in the coffin. I didn't quite finish the job. And that's another thing that I have regrets over. And part of it is because I had to move here, that I couldn't quite do that. But there are also lessons about it. As research is also about relationship in that sense. All these things that I talk about, but what I remember is not about the negative studies, but it's more about the people that I worked with. David Yu, one of my best friends, who was a cardiac surgery chief at Yale, and Fritz Sieber, who was an anesthesiology chair at Hopkins, and Keith Hawkins was my neuropsychologist, and Leslie Scott, bless her heart, she did all the transcranial Doppler for free, and gave us all the analysis. She was a director of ultrasound at Yale. So I have lots of wonderful memory. And it was also really hard because I had to collaborate through multiple departments, cardiac surgery, cardiology, anesthesiology, radiology, neurology. I'm probably skipping a few things. But part of it was kind of interesting in that sense that maybe that's how I learned to be an administrator and become a chair. Who knows, right? And the lesson that is also important is that despite all these shortcomings, we ended up training several faculties and trainees. And I also learned a lot running this team as well. Now Mark Oldham has a K23 grant that is finishing up. Sort of is a spin-off from the overall, the R01. He's looking at surgical valve replacement surgery. And goodness, his retention rate, 92%, 7%. Now, obviously, the lessons that I learned, I don't know if I passed on it, but at least I was able to teach him how important it was. And out of the 100 people, he does polysomnography, actigraphy, and he does just as intensive delirium and cognitive assessment. And certainly he does a lot better than I've ever done. And Joy Choi, who also worked on some of these analyses, now is working on a very nice QI project related to addressing psychiatric issue in cardiothoracic surgery right now, which is very exciting. And that's another thing that's doing. And there are also a lot of medical students and a lot of trainees and who went on to analyze, present data, and do everything, and became, I don't know, went to medical school and etc. And a lot of wonderful things also happened. And you know, that little baby obviously now is in medical school, and that stethoscope is still in his neck, and time just really flies fast. You know, being a neuropsychiatry fellow, kind of wondering about what to do to now here as a chair. So to me, the research has been as much about process as it is about results. Results are important, but the people you come across over the years has been more important, especially in Rochester. It's a wonderful environment that you get to meet, you get to make friendship. And it was the research that also prepared me for future. But the other thing that I want to emphasize is that this is how I also learned to respect and really value our researchers in our department as well. You know, it's difficult. Research is really difficult. If there's one lesson that I learned was that it was really hard to do these two researches. And in a way, I escaped research career to become a chair. I don't know if it was the right decision. And I also know that, you know, lately there has been a lot of discussions and talking about fundings and funding crunch and etc. But, you know, looking back, it is also a very rewarding experience in a way. And there's still part of me that actually craves developing hypothesis. Time to time, I still jot it down and think about how I want to test it, see if someone else can test it for me, and I miss it. There's this something that burns in me that still wants to, you know, test hypothesis, write grants, kind of envy people who are doing it. Yeah. So anyway, I also wanted to just let you know that, you know, those researchers in our department, you know, stand strong. We'll get through this, and because I know what you're going through. All right. Okay. Thank you.
Thank you so much, Dr. Lee. I'm very impressed with a few things. You know, probably the three biggest takeaways is how genuine and earnest is your biopsychosocial approach to, sounds like, most of your career. I just think this is a beautiful example of that. Number two, how critical the scientist-clinician model is. So everybody in this room, I think, can see some part of themselves in the stories that Dr. Lee told. But that number three, the real key is finding your collaborators and teammates. And I just think that the findings, as well as the stories about all that you've learned, really illustrated that. So thank you so much for telling us how the proverbial sausage is made. I am curious from folks in the room, what questions you have for Dr. Lee. Everybody's very busy with getting your QR code scanned. Thank you, Sean.
Thank you, Ben. That was informative and also really fun. So thank you for that. My question was if you thought about using all of our PROMIS data, depression data in our medical center to explore some of these hypotheses at scale.
Yeah, you know, I haven't really thought about it. It's a very underutilized data that we should definitely make something out of it. And, you know, like some of our Q-Core and the QUIP team that we are developing is trying to gear toward that. But I admit that it's been really difficult. You know, like one of the things that I wonder is that as a medical center, and not just our department, they should really support some of the secondary analysis related work at an institutional level to make better use out of it. But we have not just been doing that much. So that's really unfortunate. Yeah.
Speaking as a patient, I would find that very gratifying because every time I answer those questionnaires, I wonder who's looking at the results. So I think it's a really good question and hopefully should inspire us to be thinking bigger about the big data that we already have at our fingertips.
Yeah.
Thank you. Others? I hear a throat clearing from over here.
Thanks, Ben. That was very interesting. My question is, well, two parts. One is, do you think that maybe the carotid Doppler doesn't give you the most accurate assessment of the brain perfusion? And second, there's some really interesting research happening now on white matter intensities in retinal tissue, which can be examined in just very short scans that are non-invasive in just a few seconds. So that, again, if you ever wanted to do something like that here, those are data that could be collected pretty quickly. In addition to the perfusion in the retinal, central nervous system tissue. So I think the basic idea is good. I wouldn't give up on the whole idea of vascular depression and all that. I think there's still ways that could be looked at that might even support your original hypothesis.
So Steve, you're really right. I mean, I think the OTC type of these retina scan kind of measures are actually better than the transcranial Doppler that we are utilizing. So in fact, I tried to pursue that use of retinal measures as a predictor of post-operative delirium and especially depression. Now, I think delirium, we are actually working on it unless I'm mistaken. Because I know that Mark Oldham was working on some aspects of it. The odd thing, though, is that what I'm told is that in Rochester, post-cavus depression is really rare. So some of these work is right now sort of apparently not doable. So I don't know, but I totally agree with you. It's something that I wish I could do. But I think it still irks me that I had an opportunity to do an MRI-based study and I didn't quite finish it because that would have just done it. So.
Hi, Ben. It's Daniel McFarland here. Here. Just, I have a question. I think I remember seeing this right, but the pre-CABG depression predicting post-CABG depression, the confidence interval was pretty big.
Mm-hmm.
So do you think, and the other thing I'm wondering is, was there a way to measure the sort of burden of coronary artery disease and, perhaps those patients with more coronary artery disease, came in with a higher level of depression and certainly maybe left with a higher level of depression. Just wondering if that was something that you were
I think
analysis or something.
It's something that we did think about. For example, you could, look at number of the vessels that's affected, or number of the percentage blockage that's affected, or something like that as a way of also thinking about this. And that probably is part of the criticism about vascular depression hypothesis, is that, it actually goes back to my conversation with Jeff Linus many, many years ago. I don't know if everybody knows who he is. Jeff was our senior department. I think he was a vice chair of education, and later he was a vice dean, and now he's the president of the American Board of Psychiatry and Neurology. He was actually also a mentor for this particular R01 grant when I was attending what was called the Advanced Research Institute for Geriatric Psychiatry. And he was saying somewhere around there, he's talking about, I don't know about this vascular depression hypothesis. It seems like it's sort of underemphasized or diminishes the importance of overall medical burden. because, you know, these people who have all these white matter lesions tends to have a lot about comorbidities, and are you really doing an adequate job of adjusting for it? And to this day, I think the vascular depression hypothesis remain more or less a hypothesis. There's still people are searching for direct evidence. It sort of makes sense, but you know, but you know, how important it is. We are still testing, I think.
I don't know about you, but all this talk about cabbage also reminds me to say thank you to Dr. Lee for bringing back lunch. For those of you who are attending by Zoom, you have missed out, but it will be back. And for those of you who, yeah, please a round of applause for that. Please tell your friends, because the last thing I want to do is have lunch come back and then have nobody eat it. We will continue to overbuy, but we're going to do our best to be good financial stewards. Thank you so much for a fascinating talk and for your generosity. And we'll see you next week.
All right, thank you.